complex mechanistic why of the heart's wiring into the highly practical clinical how by totally decoding fascicular blocks. If you've ever stared down an ECG and wondered what those subtle axis shifts are actually trying to tell you about your patient's underlying pathology, well, you are in the exact right place.
All right, here's our cognitive roadmap for this explainer. We'll be moving briskly through the heart's conduction highway, ischemia and vascular vulnerability, decoding the ECG axis, complex conduction blocks, and finally, emergency evaluation and management.
Let's kick things off with Section 1, the heart's conduction highway, wiring the ventricles. So just so we're all starting from the exact same baseline here, what actually is a fascicular block? Well, think of it as a severe traffic jam in a very specific lane of the heart. Normally, electrical signals are blasting down these pathways at over 2 meters per second. But when a blockage pops up in one of the specialized branches of the bundle of His, it creates this highly predictable downstream delay. The signal does eventually get where it needs to go, but it's forced to take a slower, alternate route. And that delay, that is exactly what we end up seeing printed out on the ECG. Think of this central highway, the bundle of His, as bifurcating into 3 distinct lanes. Each one is responsible for rapidly delivering an electrical signal to a very specific neighborhood of the heart muscle. First, you've got the right bundle branch, which handles the right ventricle and the septum. Then, the left side splits into 2 distinct fascicles. You have the left anterior fascicle, routing signals to the anterior and lateral walls of the left ventricle, and the left posterior fascicle, which takes care of the posterior and inferior left ventricle. Truly understanding this map is the absolute foundation for everything we're about to cover.
Moving right along to Section 2, ischemia and vascular vulnerability, structural breakdowns.
Now, what's really fascinating here is how a physical pathway's vulnerability to blocking is directly tied to its blood supply redundancy. Take the left anterior fascicle, for example. It is thin, it's long, and honestly, it's incredibly fragile. It relies almost entirely on a single blood supply from the left anterior descending artery, the LAD. So when ischemia hits, this pathway gets obliterated pretty easily. But contrast that with the left posterior fascicle. This one is thick, short, broad, and boasts the highly robust dual blood supply from both the LAD and the right coronary artery. Because it's so well protected, an isolated block in this posterior pathway is exceptionally rare, and if you do see it, it usually points to some severe diffuse underlying pathology.
And while ischemia and coronary artery disease are absolutely the primary culprits for these blocks, it's really vital to recognize the other drivers at play. Degenerative fibrosis, like Lev's disease, can simply wear these pathways down over time. We also have to keep infiltrative or inflammatory diseases on our radar, things like myocarditis, sarcoidosis, and amyloidosis, which physically disrupt the tissue itself. Oh, and we definitely can't forget iatrogenic causes. Sometimes during cardiac surgery or a transcatheter valve replacement, these incredibly delicate pathways can be inadvertently injured.
Section 3. Decoding the ECG axis, reading the signs.
Think of this diagnostic matrix as your ultimate clinical cheat sheet. When a fascicle blocks, the overall electrical depolarization vector gets physically pulled toward the healthy, unblocked tissue first, followed by the delayed activation of the blocked territory. And notice how this physical reality creates a highly predictable left axis deviation. We're talking between -45 and -90 degrees for left anterior fascicular block. Conversely, it creates a right axis deviation for left posterior fascicular block. You can also pick up on specific lead patterns, a small Q and big R in high lateral leads for the anterior block, and it's reversed for the posterior block. Now importantly, both of these isolated fascicular blocks typically keep the QRS duration under 120 milliseconds, which is totally unlike a full right bundle branch block.
To really lock this into your brain, we're going to use the LEFT mnemonic to quickly recall the criteria for a left anterior fascicular block. L is for left axis deviation. E reminds us to exclude other causes, which is absolutely critical, by the way. You have to check for mimicking deep Q waves from an inferior MI, or consider left ventricular hypertrophy, because that can independently alter the vector. F stands for front or anterior fascicle, and T reminds us that it is thin with a single blood supply, making it highly vulnerable.
Now, for the exceedingly rare left posterior fascicular block, we use the PROS mnemonic. P means the axis points right. R reminds us of the mandatory RVH, right ventricular hypertrophy exclusion, along with ruling out lateral MI or pulmonary hypertension. O stands for often rare, just reminding you that this is a true diagnosis of exclusion. And finally, S stands for short, thick, and safe, all thanks to that robust dual blood supply we talked about earlier.
Section 4. Complex conduction blocks, multiple failures.
Which begs a pretty urgent clinical question, right? What exactly happens when our electrical highway experiences a multi-lane pileup, forcing the entire heart to rely heavily on a single solitary remaining pathway to activate the ventricles?
Well, that brings us to bifascicular blocks. Since the right bundle branch and the left anterior fascicle both rely heavily on the LAD blood supply, an ischemic event can readily obliterate both of them at the exact same time. This makes their combined failure the absolute most common bifascicular block you're going to encounter. A right bundle plus a left posterior block is much less common, and a combination of both left fascicles failing, that is incredibly rare, extremely high risk, and practically guarantees progression right into a complete AV block.
Now here is something you absolutely cannot afford to miss. You must recognize that alternating bundle branch blocks on an ECG are a deeply ominous predictor of sudden complete heart block. It unequivocally demonstrates bilateral severe failure of the entire His-Purkinje system. This is a massive leap in danger from a benign, isolated first-degree AV node delay. If you see the block alternating from right to left, the entire highway system is basically on the verge of total collapse.
Section 5. Emergency Evaluation and Management, the Frontline Protocol.
When a patient rolls into the ED, you've got to follow this rigid protocol step by step. Start right at step 1 with general hemodynamic stability. Step 2 is obtaining a 12-lead ECG and vitally initiating continuous telemetry. Let me be clear, continuous monitoring is absolutely mandatory for high-grade blocks and any presentation involving syncope. Step 3 is securing paramount IV access, and Step 4 rounds it all out with a comprehensive history, looking at medications, electrolytes, getting troponin testing, and an echocardiogram to check for structural disease.
A massive part of your evaluation is playing detective and interrogating the block by comparing the current ECG to prior records. If the bundle branch block is old, meaning it perfectly matches previous ECGs, it's considered chronic and stable, and the patient just gets standard baseline care. However, a brand new block, or one where absolutely no prior ECGs are available to compare against, demands immediate, aggressive investigation. You've got to rule out an acute MI, acute myocarditis, or some sort of rapidly progressive degenerative disorder.
Now, what if you're dealing with the left bundle branch block? Well, that naturally skews the ECG, right? It makes typical ischemia incredibly hard to spot. That's exactly when you deploy the modified Scarboza criteria. You're looking for concordant ST elevation greater than 1 millimeter in any lead, concordant ST depression greater than 1 millimeter in V1 to V3, or proportionally excessive discordant ST elevation. These criteria allow you to rapidly diagnose if an underlying ischemic event is happening right in front of you, cleverly cutting through all that visual noise caused by the block.
And we really have to highlight this specific trifecta: a new right bundle branch block, plus a left anterior fascicular block, plus an anterior MI. If you see this pattern, you are looking at a catastrophic indicator. This points to massive, extensive septal necrosis involving the proximal His-Purkinje system, likely due to a proximal LAD occlusion. It carries a staggeringly high mortality rate, poses a massive risk for refractory shock, and absolutely mandates high-intensity coronary care unit admission with prophylactic temporary pacing and urgent electrophysiology intervention.
Throughout all of this, the central theme is really risk stratification. And the ultimate red flag rule you need to sear into your brain is this: think syncope equals intermittent complete heart block until proven otherwise. If a patient with any fascicular block is presenting with syncope or pre-syncope, you have to treat it as an impending total highway failure.
We've mapped out the anatomical.
We're focusing on a very specific type of short circuit called fascicular blocks.
Right. And what Dr. Asifullah does so brilliantly in his teaching is he bridges this really difficult gap. He connects the mechanistic why, like the physical structural anatomy of the heart, directly to the clinical how.
Exactly. How a doctor actually uses that knowledge to manage the panicked patient sitting right in front of them.
I really appreciate how he sets up the foundation right at the beginning of the video, too. He introduces this core metaphor that takes this totally abstract medical concept and makes it instantly relatable.
The highway metaphor.
Yes, the highway. He says to think of the heart's electrical system like a massive interstate highway system. It doesn't just go in one straight line, it bifurcates. It splits off into highly specialized lanes to get the electrical traffic exactly where it needs to go.
And at the exact millisecond it needs to be there. Yeah. That highway metaphor is honestly the perfect lens for this. Because understanding these electrical pathways isn't just about memorizing arbitrary squiggles on a page.
Right, which is a mistake I think a lot of students make.
A huge mistake, yeah. It is entirely about understanding anatomical vulnerability. The physical layout of the heart muscle, and specifically where its blood supply comes from, dictates exactly where the electrical system is going to fail.
So you literally cannot understand the traffic jam, the block, until you understand how the construction crew built the roads in the first place.
Exactly.
So let's lay out that map for everyone listening. The electrical signal originates at the very top of the heart. It travels down, moves through a sort of toll booth, which we'll definitely break down later, and then it hits the main central interstate.
Right, and in medical terms, that central highway is called the bundle of His.
Bundle of His, okay. And from that central point, the highway splits into distinct lanes to carry electricity down into the massive lower chambers of the heart, the ventricles.
Yeah, so from that central bundle of His, one lane veers off to the right. This is appropriately named the right bundle branch.
Makes sense.
Its job is to supply electricity to the right ventricle and the septum, which is just the muscularly dividing wall between the left and right sides of the heart.
But the left side of the heart, the left ventricle, is like a completely different beast, right?
Oh, absolutely. It is the heavy lifter. Its job is to forcefully pump oxygenated blood out to your entire body, literally all the way down to your toes. So because it is so massive, its electrical highway has to split again into two distinct pathways, or fascicles.
Okay, so we have the right bundle branch on one side, and then on the left side, we have the left anterior fascicle, the LAFV, which routes traffic to the front and the side of that chamber.
The anterior and lateral left ventricle, yep.
Right, and then we have the left posterior fascicle, the LPFB, routing traffic down to the back and the bottom.
The posterior and inferior left ventricle, so that is 3 main lanes total covering the bottom of the heart.
Okay, so now we arrive at that concept of anatomical vulnerability you mentioned. Dr. Asifullah makes a big point about vascular redundancy.
Yeah, in cardiovascular medicine, everything revolves around vascular redundancy. It simply means how many distinct blood vessels are keeping a specific piece of tissue alive.
So it's basically about backup generators.
Exactly. A fascicle's vulnerability to breaking down or blocking is directly tied to that redundancy. If it has backup generators, it is safe. If it doesn't, it is in grave danger.
And his lecture makes it super clear that these lanes were not built equally at all. Like, let's look at the left anterior fascicle, the LAFB. Physically, it is thin and it is long.
Right, but the crucial flaw is its blood supply. It relies almost exclusively on a single blood supply, the left anterior descending artery, commonly known as the LAD.
So that single point of failure gives the anterior fascicle the absolute highest ischemic vulnerability in the entire system, right?
Absolutely. Ischemia just means a lack of blood flow and oxygen. So if a patient develops a clot or a severe blockage in the LAD, which unfortunately is a super common site for massive heart attacks.
The widowmaker.
Exactly. That thin, long electrical pathway is starved of oxygen immediately. It has no backup, so that lane shuts down and the tissue dies very quickly.
Wow. But then you contrast that with the other side, the left posterior fascicle. The anatomy is just completely different. It is thick, it is short, and it has this incredibly robust dual blood supply.
Yeah, it pulls blood from both the LAD and a secondary source, the right coronary artery or posterior descending artery. That dual supply acts as a brilliant biological failsafe.
So because it is so well protected, seeing an isolated block in just the posterior lane is exceptionally rare.
Extremely rare. If a doctor does see an isolated LPFB on an ECG, a giant alarm bell goes off.
Really?
Because it tells them instantly that they aren't looking at a minor localized issue. They are looking at severe, widespread, diffuse pathology, something aggressive enough to overcome two separate redundant blood supplies.
Okay, I want to give everyone a visual here. Imagine the left anterior fascicle is basically a tiny, fragile rope bridge spanning a massive gorge, right, hanging by one single support cable.
I like that.
If a storm rolls in and that one cable snaps, the bridge is instantly gone. But the posterior fascicle is like a massive, thick, concrete highway bridge supported by two giant reinforced pillars.
Right, so if you walk outside and see that thick concrete bridge collapsed, something truly catastrophic, like a massive earthquake just ripped through the area.
Exactly. And those storms or earthquakes taking down the bridges are what you call pathophysiological drivers, right?
Yeah.
Like ischemic injury.
Yeah, coronary artery disease, physically choking off the blood flow, is the most common. But the structure can also collapse due to degenerative problems.
Like what?
Well, there's a condition called Lenegre's disease, where the conduction system basically just ages, wears out, and turns into scar tissue over time.
Oh, wow, just from aging.
Yeah. And you can also see infiltrative causes, things like myocarditis or sarcoidosis, where severe inflammation or abnormal proteins physically invade the heart muscle and tear that concrete bridge apart from the inside.
Okay, so we know where these blocks happen anatomically, and we know why the structures are vulnerable. But here is the massive question for anyone trying to decipher that pink grid paper.
How does it change the squiggles?
Yes. How does a physical roadblock deep inside the heart muscle actually alter the lines we see on the outside?
Right. Well, to understand the paper, you have to understand vector mechanics. When a cardiologist says vector, they are simply talking about the average direction that the wave of electricity is traveling through the heart.
In three-dimensional space.
Exactly. In a healthy heart, all the electrical lanes are wide open.
Yeah.
The electricity flows down the center and smoothly sweeps out to the left, activating that massive left ventricle in one coordinated squeeze.
But what happens when one of those lanes is closed? Like, if the anterior fascicle blocks, where does the electricity go?
Dr. Asifullah explained a really fascinating physical mechanic here. Electricity always takes the path of least resistance.
Right.
So when a lane shuts down, the overall electrical vector is physically pulled towards the healthy, unblocked tissue forced.
Because the signal can't just stop. It speeds down the thick, healthy posterior lane instead.
Exactly. Because of this, the healthy, unblocked territory activates or depolarizes first. But the heart is a machine. That blocked anterior territory still has to beat, or the patient dies.
So what happens?
The electrical signal has to laboriously spread cell by cell away from the healthy side, slowly wrapping all the way back up to activate the blocked side.
Wait, I want to make sure I'm visualizing this detour correctly. The electrical signal essentially hits a wall, so it floods down the open lane, and then it has to slowly U-turn and push its way through the actual muscle tissue to get back to the blocked area.
That is exactly what happens, yes.
And because it arrives so late to the blocked side, it drags the overall average direction of the electricity off-center.
Spot on. That U-turn creates a massive lopsided electrical shadow. In cardiology, we map the heart on a 360-degree compass called the hexaxial wheel.
Okay.
When the signal is forced to take that slow cell-by-cell U-turn toward the blocked area, it physically shifts the average direction of the electricity on that compass. We call that an axis deviation.
Okay, before we get into the specific degrees on that compass, I want to clarify some of the heavy medical jargon that gets thrown around. When doctors look at an ECG, they talk about leads and the QRS complex.
Sure.
For someone who's never studied this, what are we actually looking at?
A really great way to think of ECG leads is to imagine 12 different security cameras mounted in a circle around the outside of a building.
And the building is a heart.
Right. Each camera, or lead, is just looking at the exact same electrical event from a slightly different angle. Some cameras look from the bottom, some from the left side.
And what about the QRS complex?
The QRS complex is the massive, sharp spike you see on the paper. That spike represents the physical moment. The giant lower chambers, the ventricles are flooded with electricity and violently clench down to pump blood to your body.
That makes the criteria so much easier to digest. So let's look at the specific detour caused by the left anterior fascicular block, the LAFB.
Okay.
Because the signal takes that massive U-turn toward the blocked front left area, it pulls the compass needle with it, causing what you call a left axis deviation.
Exactly. Specifically, the vector shifts between -45 and -90 degrees on the wheel.
And the QRS complex, that big spike, usually stays relatively narrow, under 120 milliseconds. And depending on which security camera you look through, you see a specific pattern.
You see a small dip, then a big spike in the cameras looking at the side of the heart, and a small spike, then a deep dip in the cameras looking from the bottom.
But trying to memorize those specific spikes and dips while a patient is crashing has got to be incredibly difficult.
It is really stressful, yeah.
Dr. Asifullah clearly knows that struggle, because he provided an amazing mnemonic in the video to lock the LAFB criteria into your brain. To remember the features, you just use the word FT, L-E-F-T.
It is a great memory tool.
Yeah. So L stands for left axis deviation. E reminds you to exclude other causes. F stands for front, because it is the anterior fascicle. And T stands for thin, reminding you it has that fragile, thin, single blood supply.
I love that. Compressing complex clinical anatomy into a single functional word is just the mark of a great teacher.
Totally. And he applies the same logic to the left posterior fascicular block, the LPFB. Remember, if the posterior lane is blocked, the U-turn happens in the exact opposite direction.
Right, the signal rushes down the front, then slowly drags back toward the bottom right.
Which pulls the compass needle the other way, causing a right axis deviation between positive 90 and positive 180 degrees.
And the mnemonic he uses for this one is the word points, P-O-I-N-T-S.
Let's break that down.
P is for points, right, giving you the right axis deviation. O is for often rare, because an isolated block here almost never happens.
Right.
And reminds you that the inferior leads, the bottom cameras, will show the big positive spikes. N is for narrow QRS, meaning the spike isn't overly wide.
And T is for two blood supplies, which is why it is so robust. And finally, S is for short and thick, referencing its physical concrete bridge structure.
The clinical utility of those acronyms is just fantastic. But I do need to point out a massive trap here for any new clinician.
Oh, what is the trap?
You mentioned the letter E in the LFT mnemonic, exclude. Diagnosing these specific electrical blocks requires mandatory exclusions.
Meaning you can't just jump to conclusions.
Exactly. A doctor cannot just glance at the paper, see the compass needle pointing left, and scream, left anterior fascicular block.
Why is that? Like, are there other things inside the chest that can drag the electricity off center?
Oh, absolutely. Muscle mass and dead tissue exert a massive physical pull on electrical vectors.
Wait, really? Just the physical mass of it?
Yeah. Imagine a patient with severe, uncontrolled high blood pressure. Over the years, their left ventricle has had to pump so hard against that pressure that the heart muscle becomes massively overgrown, kind of like a bodybuilder.
Okay.
We call that left ventricular hypertrophy. That huge wall of extra muscle requires so much electricity to fire that it will physically pull the compass needle all the way to the left, totally mimicking a block.
Wow, I didn't even think about that.
And alternatively, if a patient previously suffered an inferior myocardial infarction, a heart attack that killed the muscle at the very bottom of the heart, that dead tissue acts like an electrical void.
So the electricity flows away from the dead zone, pushing the vector up and to the left.
Exactly. A doctor has to methodically rule those structural issues out before blaming the wiring.
It is a game of clinical elimination. You see the U-turn on the paper, but you have to verify that the detour wasn't caused by a massive muscular wall or a crater of dead tissue before you blame a broken wire.
That is the exact diagnostic process, yes.
Yeah. So we have spent a lot of time on single-lane closures. But in the real world, human disease rarely stays politely confined to one single lane. What happens when multiple highways shut down simultaneously?
Well, the transition from a fascinating anatomical quirk to a highly dangerous, life-threatening emergency happens right here. When multiple lanes shut down, we enter the territory of multifascicular threats.
Sounds ominous.
It is. The most common scenario you will encounter is a bifascicular block.
Bifascicular meaning 2 out of the 3 main ventricular lanes are completely closed down, leaving the entire massive structure of the lower heart heavily reliant on one single solitary pathway to keep beating.
Exactly. And the classic combination that presents in the emergency room is a right bundle branch block paired with a left anterior fascicular block.
And if we think back to the vascular redundancy we discussed earlier, the why behind that specific combination makes terrifying sense.
It really does.
The right bundle and the left anterior fascicle share the exact same blood supply, the LAD artery. So one severe ischemic event, one bad clot in that specific pipe, can instantly wipe out both of those lanes at the exact same time.
The plumbing fails, and 2 of the 3 electrical wires simply starve and die.
Terrifying.
But there is a less common but exponentially more dangerous combination. That is the left anterior fascicle failing alongside the left posterior fascicle.
So both left-sided lanes.
Yes. If both of the left-sided pathways fail, the heart is entirely reliant on the right bundle to basically push electricity backward across the septum to activate the left heart.
That sounds incredibly unstable.
It is a highly precarious state that frequently degrades into complete AV block. When complete AV block happens, the top chambers and the bottom chambers of the heart stop communicating entirely.
The central highway just collapses.
Exactly.
Dr. Asufle actually brought up a pretty scary rule of thumb regarding this called the syncope rule. Now, syncope is just the formal medical term for fainting or passing out, right? So the rule states that any bifascicular block on an ECG paired with a patient who reports fainting equals, and I quote, intermittent complete heart block until proven otherwise.
Yeah. If you are evaluating a patient, this is a blaring red siren. Think about the physical mechanism of fainting. The brain briefly stopped receiving enough oxygenated blood.
Right.
So if you look at their ECG and see 2 electrical lanes are permanently closed, and the patient tells you they randomly passed out, you must assume that the third, final lane is sputtering.
Like it briefly closed down, the heart stopped pumping, the brain lost oxygen, and they collapsed.
And the lane opened back up just in time for them to wake up. You have to treat that patient as a near-miss cardiac arrest.
As scary as that is, the lecture introduced a concept next that completely blew my mind. It is called the trifascicular illusion.
Oh, this is such an important concept.
Let's say you are looking at an ECG. You clearly see a right bundle branch block. You also clearly see a left anterior block. 2 lanes are down. But then you also notice what doctors call a first-degree AV block, which means the electrical signal is taking an unusually long time to even get started. So looking at the paper, it seems like all 3 systems are failing simultaneously.
Right. The technical term for that delay is a prolonged PR interval. And when a clinician sees those 3 things together, the temptation is to jump to the worst possible conclusion.
Naturally.
They think, the right bundle is dead, the anterior fascicle is dead, and this massive delay means the final posterior fascicle is dying too. Complete catastrophic failure is imminent.
But let's explain what the AV node actually does, because that is the key to the illusion, right? Yeah. Earlier we called the AV node a toll booth. Why does the heart need a toll booth slowing down electricity in the first place?
Well, the heart is a 2-step mechanical pump. The top chambers, the atria, fill with blood. They need to squeeze that blood down into the massive bottom chambers, the ventricles. But if the electricity traveled instantly from top to bottom, the whole heart would squeeze at once, and no blood would go anywhere. They would just be fighting each other.
Right.
So the AV node is a specialized cluster of cells sitting right in the middle of the heart. Its entire biological purpose is to physically catch the electrical signal, hold onto it for a fraction of a second to let the top chambers finish emptying, and then release the signal down the highway.
And that intentional pause is what you see as the PR interval on the grid paper.
Exactly.
So relating this back to the trifascicular illusion, it is like looking at a highway system and seeing a traffic jam blocking the right lane, a traffic jam blocking the left lane, and then assuming the middle lane is completely blocked too, just because no cars are coming through.
That is a great way to put it.
But the illusion is that the middle lane might actually be perfectly fine. The real problem is just that the toll booth at the very beginning of the highway, the AV node, is just processing cars really slowly today.
Yeah, the delay is usually isolated entirely to the AV node.
Yeah.
The tissue in the third fascicle might actually be perfectly healthy.
Oh.
So assuming it is a full trifascicular block is a clinical illusion that can lead to aggressive, unnecessary treatments. True, extensive failure of the entire system doesn't look like a slow toll booth. It looks chaotic. It looks like alternating bundle branch blocks.
Meaning you watch the monitor, and 1 minute the entire left side of the highway is blocked, and the next minute the left side opens, but the entire right side is blocked.
Yes. An ECG showing an alternating right and left bundle branch block is unequivocal evidence of bilateral severe failure of the entire infrastructure. The system is desperately trying to route electricity, and every path is collapsing.
That is terrifying.
It is an ominous predictor of sudden complete heart block and sudden cardiac death.
Which brings us to the ultimate crucible of this deep dive, the ER reality check. We have all this incredible anatomical highway knowledge. We understand the vector mechanics pulling the compass needle. But how does a doctor actually apply this directly in a high-stakes emergency setting?
That is the million-dollar question.
Like when you see these patterns on the pink paper, how do you decide who gets discharged to go home and who gets rushed into the intensive care unit?
The entire triage process hinges on differentiating between a benign quirk and impending failure.
Okay.
Let's say a patient comes in for a routine physical, they have no symptoms, no structural heart disease, and their ECG shows an isolated left anterior block. In most cases, there is no emergency management required.
Because their electrical vector takes a U-turn, but the heart pumps fine. It is just a stable quirk of their personal wiring.
Exactly.
The crucial distinction there seems to be the word stable. The difference between a new block and an old block dictates everything that happens next.
It really is the clinical difference between a cold case file and an active bloody crime scene.
Oh, wow.
If you find an old bundle branch block by, digging up the patient's previous ECGs from 5 years ago and seeing the exact same pattern, they receive standard baseline care. The bridge collapsed 5 years ago, and their heart successfully adapted to the detour.
But a brand new block.
The new block demands immediate aggressive investigation.
Because a brand new block means a bridge just collapsed today.
Yeah.
Something active and aggressive is currently chewing through the electrical wiring right at this very second, like an acute bout of myocarditis or a brand new heart attack.
Yes, and finding that active heart attack becomes the clinician's biggest challenge. When a bundle branch blocks, especially the left bundle, the right and left ventricles lose their synchronized timing. They fire totally out of sync.
Okay.
This creates a massive, wide, chaotic electrical collision on the ECG paper, and that chaos can completely hide the subtle ST segment changes that normally warn a doctor about a heart attack.
Dr. Asufle stressed this heavily. He talked about something called the modified Scarbosa criteria to see through that chaos. What is the actual mechanism they're looking for there? What is an ST segment?
So the ST segment is the flat baseline on the grid paper immediately following that massive QRS heartbeat spike. If that baseline gets yanked violently upward, it usually means heart muscle is currently suffocating.
And Scarbosa helps you find that suffocation even when the block makes the lines chaotic.
Exactly. Clinicians look for ST elevation of more than 1 millimeter that moves in the same direction as the chaotic spike. We call that concordant elevation.
Okay.
But the most vital metric is looking for excessive discordant elevation. They use a very strict mathematical formula, an ST to S ratio of less than or equal to negative 0.25. If the baseline moves out of proportion to that specific ratio, the block is hiding a massive ischemic event.
It is basically an incredible mathematical filter to find the real danger. But what about the absolute worst-case scenario? The lecture laid out an ECG pattern that acts as the ultimate catastrophic indicator.
Oh, yeah.
A patient arrives, and the paper shows a brand new right bundle branch block, plus a brand new left anterior fascicular block accompanied by an anterior myocardial infarction.
That triad is a cardiologist's nightmare.
Okay.
Because of our anatomical map, we know exactly what is happening in three-dimensional space. The proximal LAD, the very top of the widowmaker artery, is completely blocked. It is causing massive, extensive necrosis, which is irreversible tissue death across the entire septum. The lack of blood is simultaneously killing the right bundle, the anterior fascicle, and the front wall of the heart muscle all at once.
Man, if you are ever looking over a doctor's shoulder at an ECG, seeing that specific combination of words is the literal difference between taking a deep breath and slamming the panic button.
Truly. The risk of that patient abruptly going into complete heart block and refractory cardiogenic shock is just staggeringly high.
So what is the protocol?
The management mandate isn't just observation. It requires immediate admission to a high-intensity coronary care unit. They need continuous telemetry monitoring. They require prophylactic temporary pacing.
Which means a cardiologist physically floats an electrical wire through a vein directly into the heart so a machine can pace it the second the biological system fails.
Exactly, because you can't just treat the squiggles on the paper.
You never treat just the paper.
Right. The ECG gives you the geographical roadmap of the vulnerabilities, but you have to evaluate the actual terrain of the patient.
Right.
You evaluate their hemodynamics, meaning is their blood pressure crashing? Is their pulse fading? You take a rigorous history to ensure a toxic medication isn't causing the block.
And you check their blood for troponin, which is that specific protein that heart muscle cells only spill into the bloodstream when they are actively dying.
Exactly. The ECG tells you where the bridges are collapsing, but the patient's physical state tells you how to save them.
The journey from looking at a chaotic piece of pink grid paper to understanding the profound physical mechanisms underneath it is just incredible.
It really is.
We've gone from Dr. Asufula's concept of the three-lane anatomical highway down into the fascinating physics of vector shifts pulling electricity toward healthy tissue, all the way to the high-stakes ER mathematics of the Scarbosa criteria. It completely changes how you look at those zigzagging lines. They aren't random seismograph scribbles at all. They are a perfectly precise, real-time geographical map of a system desperately trying to adapt to failure.
They tell a mechanical story of survival, millisecond by millisecond.
Which leaves us with a rather provocative thought to chew on as we wrap up. When you look at the evolutionary biology of the heart's electrical system, it was clearly engineered with a brilliant fail-safe.
The redundancy.
Yes, it has heavy vascular redundancy in that posterior fascicle and multiple pathways designed to keep the main muscle pumping, even if it takes damage. But modern ischemic diseases like blockages in the LAD artery, which are heavily driven by modern diets, sedentary lifestyles, and chronic stress.
Right.
They are perfectly positioned to exploit the one major structural weakness of that entire system, the fragile single-supply interior fascicle. It really makes you wonder, as human lifespans have extended and our environments have drastically changed, are we essentially outliving the original engineering parameters of our own hearts?
That is a profound question about where human biology collides with modern pathology. The hardware hasn't changed, but the stress on the system certainly has.